Good evening. So much anticipation for this event. It really is a privilege, and I want to welcome and thank you, all of you who are here in this room at the World Health Organization's headquarters, and also all of you who have been patiently waiting virtually to join us for this official side event from global strategy to country impact, scaling emergency critical and operative care. We have around 800 people who have registered to join us. I'm going to say that again. We have about 800 people who have registered to join us. I truly believe that that's just a sliver of the enormous amount of interest that integrated emergency critical and operative care, and which we know dearly as ECOCare, means to everybody. And we understand that it has so much to do with survival, dignity, and equity. I want to welcome, for the opening remarks, our dear His Excellency Ambassador Tegab Daka, who is the permanent representative of Ethiopia to the UN office in Geneva and to the many organizations in Switzerland that he expertly manages to make sure that Ethiopia is exceedingly well represented. Your Excellency, it's really a pleasure to have you. Please welcome us all.
Thank you so much for the kind words. I am delivering this statement on behalf of Dr. Magdes Daba, the Minister of Health. She is apparently delayed on her way, so let me start by welcoming you on her behalf. Across our countries, most of the death we consider preventable happen at the moment when care is needed most. During childbirth, after an injury, when an infection becomes severe, when a patient reaches a facility but the system is not ready to respond. This is not only a global issue, it is a daily reality for our health systems. This is why integrated emergency, critical, and operative care matters. It is not one part of the system. It is what determines whether the system works when it matters most. Without it, universal health coverage cannot be fully realized, and our preparedness for health emergencies remains incomplete. Ethiopia was proud to co-sponsor Resolution WHA 76.2 in 2023, reflecting a shared recognition that strengthening integrated emergency, critical and operative care is essential to reducing preventable death. This was not only a global commitment, but a reflection of what countries are already experiencing on the ground. Today, we are at an important point. We are moving from that resolution to a global strategy and now to implementation at country level. This transition from commitment to action is where the real impact will be determined. From our experience, progress will depend on practical implementation, strong national ownership, and sustained investment in systems, including workforce, infrastructure, and essential services. We also see the importance of working together. Platforms such as the Acute Care Action Network provide an opportunity to move from discussion to coordinated action, with countries and partners aligning around shared priorities and learning from each other. Ethiopia remains committed to advancing this agenda. Strengthening emergency, critical, and operative care is one of the most effective ways to reduce preventable death and to build more resilient health systems. With this, I would like to warmly welcome you to this event and use this opportunity to thank our organizers and co-sponsors. I thank you.
Your Excellency, thank you for your incredible words. You got to start with an image of the need and transition us into exactly why we're here, which is that action-driven spirit that is going to give us impact. And we all want to recognize the enormous leadership that Ethiopia has exercised over the years in this very same topic. Thank you so much, Your Excellency. We welcome Regional Director, but I am going to ask for your forgiveness. No. You are next, but we have a...
it's understandable.
Yes, we are going to welcome the State Secretary of Norway, who after here is going to be running to the airport to catch a plane. It is a privilege to welcome the State Secretary, Dr. Usman Ahmad Mushtaq, the State Secretary of Health for Norway. He is leading national efforts in public health, digital health transformation, and health systems equity. He has a background in medicine and policy, and he's held senior roles in health governance and international cooperation. We are so happy to have you here right before you pick up your flight. We're looking forward to hearing your message.
Thank you very much. And I know that we have been insisting on him speaking now, but he is actually outside. So I am, like my good colleague from Ethiopia, stepping in for him. But if I can yield the floor on his behalf for a few minutes, I will go and get him. And you will get the real deal, not me reading out his statement. I'll be, if you can, sir, proceed in the program, I'll make sure to get him in the chair within minutes. Thank you.
Outstanding. Very good. Well, we're flexible. What matters here is obviously the work and the message and the lessons and the sharing that comes with us being together. So I'd like to welcome a Regional Director, Professor Mohammed Yakub Hanabi. Professor is a Tanzanian cardiologist, a public health expert, and the Regional Director of the World Health Organization's Africa region. It's a big shoes to fill, Regional Director, a big region. A lot of people you can support, enhance, whose livelihoods depend on the leadership of you and others who are doing some incredible work. So we welcome you to the floor.
Excellency, distinguished colleagues, allow me to begin with a story. In Seka, Chakosa district in Ethiopia, a young woman, Amina Abdi, begins to bleed heavily in the night. There's no doctor nearby. Oh, Your Excellency, I have to start all over. You are here now. So, Excellencies, Honorable Minister Dabar, distinguished colleagues, let me begin with a story. In Seka Chakosa district in Ethiopia, a young woman, Amina Abdi, begins to bleed heavily in the night. There's no doctor nearby. Her survival depends on minutes, on whether someone recognizes the danger, on whether transport arrives, or whether the facility is ready to receive her. A neighbor trained as a first responder acts immediately. A nurse trained in basic emergency care stabilizes her. Blood is available. The theater is ready. She lives, and the baby survives. That is acute care. And that is why this matters a lot to us. Because when emergencies strike, and they always do, health systems are judged not by the policies, but by their readiness. WHA 76.2 gave us mandate. This strategy gives us the framework, but the real test is implementation. Closing the gaps between community and care, between transport and treatment, and between training and tools. That is where ICON makes the difference, turning commitment into coordinated actions. When I took office 10 months ago, I said, I think Africa is not shortage of commitments. It's a shortage of implementation. So let me emphasize, resolutions do not save lives. Strategies do not save lives. Systems do. I was a CEO for our national hospital back home before I took this job in Tanzania. 2,400 beds capacity. 10 years ago, mortality rate at the emergency was almost 70%. As I speak, for the past 6 years now, it's less than 1%. Those of you who know Terry Venables, who is here at HQ, he worked with us there. These things are possible when you start to implement them. So the measure of our success is simple. More stories like Amina's. I sometimes wonder, without acute care, are we really going to cut down maternal mortality? Which ranges from Mauritius, 45 per 100,000 live deliveries, to some of the countries in West Africa, over 1,000. I've always told my students, pregnancy is not a disease. It's just a normal physiological. It just needs care. So let us move from intent to impact, from strategy to survival. I thank you.
Professor Mohammed, thanks for your very articulate, vivid, exemplary message. And that's exactly why we're here. We would like to replicate stories that lead us to that 1% you mentioned and even less. I want to acknowledge and welcome our very admired Excellency Ambassador Megdes Daba Feza. We just heard from His Excellency deliver some wonderful remarks, and we look forward to hearing yours as well. Do we have Dr. Usman? Yes, excellent. I'm sorry I didn't have the pleasure of meeting you, but we're welcome as well, Dr. Usman. Before you catch your flight, we would love to hear your remarks representing Norway in this forum. Thank you for being with us.
Thank you. Thank you so much, dear friends, dear colleagues. I think with those powerful words of Professor Janabi, it is absolutely, I think you kind of nailed the key message here. Pregnancy is not a disease. It's a normal physiological condition, and it requires care. We believe that obviously health innovations contribute to saving lives, improving quality, and strengthening health systems. And innovations can reduce costs and provide more value for the limited funding that is needed to making sure that we bend the curve of mortality. And this is even more important now as there are significant funding challenges that we're seeing across the board on global health issues. For the Norwegian government, global health is a priority. It has been a priority for many, many, many years. And innovations has been one of the pillars of our global health strategy and efforts during the last 25 years. And with great success, I would say, in making sure that we take down the mortality rates in multiple countries. I'm very glad that we have Lærdal Global Health here as well, and they have been a proactive and constructive stakeholder within the global health community and has played a positive role in mobilizing resources and forming partnerships. And we appreciate being a role model for how private sector can contribute, and we certainly appreciate our long-standing cooperation between the public and the private sector of Norway to collaborate with countries in Africa. We're excited about this new partnership between Lærdal and WHO, aiming at scaling basic emergency care at 1,000 hospitals in 5 countries within a 3-year period. And in support of this partnership, we're happy to announce that Norway support these efforts with 30 million Norwegian krones, which was announced today. Dear friends, more consolidated global health landscape and long-term health system strengthening is obviously needed to align the initiatives that with the national systems and the national priorities. And we need global health organizations that together better contribute to the strengthening of national health systems in line with a lot of the thinking that has gone over the past year, including what we also like to call the Lusaka agenda. And we should rally behind the priorities that the countries and the regions, as Professor Janabi was mentioning, the regional initiatives that exist. And in this context, equitable access and life-saving and innovative health products is absolutely crucial. So we're very glad that also this partnership can also inspire other private sector parties to contribute to global health efforts, because it is now more needed than ever. Thank you so much.
Thank you so much for your remarks. Thank you so much for this wonderful example of partnership and commitment. I think it's fair to say that everybody here is inspired and ready to take on the world as we hear leaders like you on commitments such as the one from Norway. We wish you a safe flight home as well. Thank you for being here. We would like to also welcome the words of the Director General, Ms. Yesoda Aryal, who is the Director General of the Health Coordination Division, the Ministry of Health and Population of Nepal, and spokesperson of the Ministry of Health. Welcome.
Thank you. Thank you, sir. Excellencies, dignitaries, and all the participants. Greetings from Nepal and the Nepal delegation team. I'm honored to be here to share about some of the country-level implementation of this acute care resolution that we passed last year. So Nepal welcomes this important discussion on scaling the acute care while translating the global commitments into the measurable country impact. Strengthening integrated acute care systems, including the emergency, trauma, surgical, and other aspects, is crucial for improving the survival, advancing universal health coverage, and strengthening health emergency preparedness. As a country with challenging geography, dispersed population, and vulnerability to disasters, Nepal continues to face significant barriers in timely access to the acute care, delays in receiving emergency service, particularly for injuries, obstetric emergencies, and acute medical conditions, contributes substantially to the preventable morbidity, mortality, and disability. Strengthening the continuum of care from the community level to the health facilities is therefore our national priority. In line with the WHA resolution, Nepal is actively operationalizing an integrated acute care approach across the continuum from the community to the pre-hospital and finally to the emergency care at the health facility and institutions. So we have done some of the activities to institutionalize this within our country. That includes training of the community first health responders. We have so far trained more than 400 community members and more than 800 ambulance drivers in basic emergency and life-saving skills with support from the partners, including the European Union. Strengthening pre-hospital care systems through improved referral and the transport coordination mechanisms. And we are standardizing our ambulance service because that is crucial for ensuring the proper referral mechanism. And we are also advancing our development of the heli and air ambulance standard operating procedures. Likewise, while the clients come to the health facility, our institutions should be equally ready to respond to the needs. So we are strengthening the facility-based emergency and trauma care. These efforts are helping address the first and second delays in accessing care and are particularly critical for the rural communities, disaster-prone settings, and vulnerable populations. Nepal's experience demonstrates that low-cost, high-impact interventions at the community and pre-hospital levels can significantly improve our emergency care outcomes when linked through an integrated continuum of care model. The Acute Care Action Network offers an important platform for the countries like Nepal to strengthen our technical collaboration, exchange best practices, develop standardized tools and accountability frameworks, and mobilize the sustainable investment for acute care system strengthening. Moving forward, Nepal seeks continued collaboration and support to scale those trainings, including the community first health responders and ambulance drivers, so that we can cover nationwide and institutionalize the ambulance workforce certification and competency standards, strengthen integrated dispatch, referral, and coordination systems, enhance standardized EMS protocols and governance, and ensure sustainable financing that is of utmost importance, and policy integration for the acute care systems. Nepal remains committed to working with member states, WHO, and other partners to operationalize the resolution further, ensuring that every person can access timely, quality, and life-saving acute care when it is needed, and that no patient is left behind before reaching the hospital. Thank you. Over.
Thank you so much. Thank you so much for your words, Director General Ariel. We appreciate above all your openness, your willingness to highlight challenges, your drive to action, the very specific actions you're taking, and your openness to partnerships. I would like to also welcome to the floor now Dr. Amanda Fenn, who is a registered nurse with a master's and PhD in public health and serves as a technical officer at the WHO Office of the Chief Nurse Advocacy and Partnerships within the WHO Academy. Dr. Fenn, welcome.
Thank you. Thank you so much, colleagues. Good evening, and honorable ministers, regional director, distinguished panelists, dear colleagues here in Geneva and joining us online across the globe, all the protocols observed, good evening. It's truly an honor for me to be here with you today. So I thought about starting today telling you a story as our RD did. So I will be brief because of in a matter of time, but another day, as I was doing something pretty much as all of us do, I was scrolling in social media and I saw a video about a doctor saying something that the obvious must be said. So I'm here to tell you the obvious tonight. We already know the mandate. We hear from the RD. We just hear from the Nepal colleagues here, some experience, great experience, and about what countries need. And we will hear about the enormous burden of the disease that emergency, critical, and operative care addresses globally. So what is the obvious? Two things I will bring for you tonight. So the first thing is simple things, they save lives. So community first aid responses, they can reduce mortality by up 30%. Triage systems in hospitals improve outcomes dramatically and can reduce mortality by 50%. Basic low-cost acute care interventions at hospital levels can also have an impact in 50%. Simple things that can save lives every day. The draft global strategy from integrated emergency, critical, and operative care reminds us that ECHO, it's not a luxury. It's a foundational for universal health coverage, resilient health systems, and health security. So moving from mandate to implementation, as it was already said here, we need an empowered and a supported and protected workforce. And who are them? So this brings us to the second obvious things of this evening. Across the ECHO continuum, approximately 80% of the workforce are nurses and midwives. They are often the first point of the contact with patients and communities. They coordinate care, they keep service running 24 hours per day in the most difficult and remote environments. So if we want stronger healthcare systems, we must invest in nurses and midwives. We must strengthen their capacity and support advanced nursing roles. We must strengthen leadership and allow nurses and midwives to work in their full scope of practice. We must strengthen education and multidisciplinary teamwork, because ECHO cannot work in silos, and neither can health workers. The good news is that we already have a wonderful example showing that this is possible. So Recently, we received some wonderful examples from the implementation of the basic emergency care in the Pacific region, where we moved from 2 active master trainees in one country to 179 facilitators in 16 countries in about a year. Most of them nurses and midwives. Now, our responsibility is to move faster, wisely, scale smarter, and ensure that implementation reaches communities where it needs the most. Because in many settings, saving lives starts not with the most advanced technology, but simply by making sure the obvious is understood, supported, and implemented. Thank you very much.
Thank you, Dr. Friend. We will absolutely remember the obvious, and we will absolutely remember the role of nurses and midwives in whose shoulders the dream of ECOCare for everybody certainly rests. I have the pleasure of also welcome Professor Ole Friedhof Norheim, my Latin pronunciation, maybe Professor. Professor Norheim is a professor of ethics and population health at Harvard and professor of medical ethics at University of Bergen, and he also co-chaired the Lancet Commission on Investing in Health. Welcome, Professor.
Thank you so much. I've been asked to say a little bit about the data and the evidence in this area of emergency and critical care. And I want to start with this graph. I was a member of the Lancet Commission Global Health 2050, Pathways to Halving Premature Death by 2050. And this graph shows the probability of death before the age 70 for the last half century. And the spike you see there is 2020 when we had the pandemic, and the red dot would signify halving premature death from 30% to 15% globally. And the interesting thing is that even if we are in challenging times, the trends are positive. There are unequal trajectories, but there are positive trends. And we argue that it's possible to halve premature death if countries choose to invest in health. And 2 key recommendations from the Lancet Commission was to identify the conditions associated with the most burden, and to identify the most impactful and cost-effective interventions. So let me talk about the burden first. Global health statistics doesn't classify deaths by urgency. But the best study that we have found was a work led by Zulfi Butta with data from 2015. And they classified all information from WHO and Seattle IHME, and classify them by death where the hour counts, sometimes the minute counts. And to me, the surprising result was that you see it here globally, about 50% of all deaths are related to emergency critical, or what is called here emergency medical diseases. There's a variety within across regions, of course, and we know that the age distribution is different in different countries, but you see here in high-income countries, about 25% of life years lost are due to emergency diseases. In low-income countries, more than 50%. So there's huge potential for improvement. And this table just summarizes this into maternal and neonatal deaths, approximately 4 million, injuries, trauma, approximately 5 million. This is around 2020. Sepsis, and this is of course multifactorial and overlaps with other categories, but some studies shows 11 million deaths, and we know that this can be treated, prevented and treated. Acute cardiac arrest, of course, may be around 4 million, stroke around 7 million. This sums up to 31 million deaths. And in 2020, 2019, it was around 60 million deaths, so half of this. And that shows the potential. Imagine Imagine if you could reduce this amount of deaths by 10%. That would be 3 million. I think that's too optimistic. 1%, that would be 300,000. I will propose maybe 3%. A good target that would lead to 1 million deaths that could be prevented by investing in these kind of services. We should also look at cost-effective interventions. There's a variety of interventions we can implement, of course. And there are a few studies, 2 by Werner et al. From South Africa, reviewing 30 interventions, and found, again to my surprise, very cost-effective intervention, ranging from $100 to $1,000 per disability-adjusted life year saved. And that's quite cost-effective with compared to a lot of other interventions. Another study looking at WHO emergency care toolkit in Uganda found that it was actually cost-saving. You save a lot of lives and you save future health expenditures. And I'll end with one fantastic example that many of you know about, Safer Birth Bundle of Care, that was published in the New England Journal of Medicine. High quality evidence showing that low density, high frequency training of midwives can really have an impact on child mortality, on maternal mortality. And very recently, this spring, a cost effectiveness analysis showed the impact. So the total cost of those programs was 4.5 million. Cost per life saved, 4.6 thousand. And cost per disability adjusted DALYs averted $144. And that's amazing. Experts will always tell you that if an intervention costs less than $500 or half of GDP per capita in a country, in Ethiopia, it would be $500, $600. This is very, very cost effective. And if you're interested in benefit cost analysis, this particular intervention will give a return on investment of $38 per dollar invested. So the burden of disease is substantial. Many of these interventions are very cost effective. And of course, the next big thing is about showing even better evidence for scaling up these interventions. And there we need also cost effectiveness analysis and showing the equity impact. Thank you.
Thank you very much, Professor Norheim. I happened to look to my right at a moment and I saw Their Excellencies really focused on the information, and I'm sure already thinking through actions. This first session of our gathering today has taken us through very human stories of people, providers, has shown commitment, leadership, and has shown those data that has significant room for improvement. Now we want to talk a bit more about some of the actions that are taking place and how can we scale up those actions to deliver the impact that we hope to have in the world. And what a pleasure to welcome Professor Lee Wallace, who so many of you know well, who's a Senior Technical Officer for Emergency, Critical, and Operative Care at the World Health Organization in Geneva, and a real champion of this cause. Professor.
Thanks for inviting me. Thank you for the opportunity to speak to such a distinguished panel, Excellencies, and ladies and gentlemen, thank you. Just a few words on a program that you're all hopefully very aware of. I just want to talk about how the Basic Emergency Care Program, which was co-developed with ICRC and the International Federation for Emergency Medicine, has the potential to really make an impact on the sort of burden that you've been hearing about this evening, and how we can use stories that the example that you heard from Amanda and from the regional director of individuals really having their outcomes change dramatically, particularly if we focus this course and this training on the full team of emergency care in the community, in the pre-hospital environment, focusing on nurses and midwives, and all the way through the facility, not just in the emergency unit. We know from work that has been done in several countries in Africa and in Nepal that if you implement basic emergency care with a couple of other very low-cost, simple interventions, we see very, very impressive mortality reductions on inpatient mortality across a range of conditions. And actually, if you look at under 5s and under 18s, it's somewhere closer to 50 to 60% overall. So at the cost of about $3,000 per hospital to implement this full intervention, we were seeing this dramatic impact, which is completely in line with the burden of disease and potential impact information that you heard. In order to make sure that this is not just a WHO-led study that was looking at our own tools, partners independently looked at very similar implementation. So in Liberia, basic emergency care was implemented and saw a 50% reduction in odds of mortality. The Zambia paper is passing some of the data from that previous slide, showing 34% impact. In Moldova, recently, implementation of the trauma component of basic emergency care saw about 50% impact also. So we know that this low-cost intervention really can make an incredible impact. We know the workforce that we need to target. It's primarily nurses and midwives, as they're often the first contact. They provide very much of the care for the acutely ill or injured patient. And as you heard from the State Secretary from Norway, with the announcement of 30 million Norwegian crowns adding to an already substantial pot, we have an initiative that's been led by the WHO Foundation. The Acute Care Transformation Through Basic Emergency Care was kickstarted with a very large donation from Laerdal Global Health, and then supported by the AKO Foundation and now Norwegian government. We will be, in the current iteration with the funding we have, we're at 846 facilities across 4 countries. We are starting right now with implementing this course at very large scale, aiming to get to 1,000 facilities with another country. Hopefully we'll have news on that very soon. And at the same time, measuring the impact in about 130 hospitals across those countries. So we're hoping to, over the next year or two, have some very dramatic extra evidence, and not just about the clinical impact, but about ways to take interventions like this to scale at a low cost and sustainably. Thanks for the opportunity to speak.
Professor, always a privilege to hear you, and the data shakes us up, but you are showing that there are ways, and we should not dismay, but move forward. I'd like to welcome Dr. Joe Boney, the president of the African Federation for Emergency Medicine. Dr. Boney is also a medical specialist from Ghana, and we are following up with the same theme of scaling up. We're looking forward to hearing you, Dr. Boney.
Thank you very much. And it's an honor to speak to the honorable ministers and regional director and distinguished colleagues, ladies and gentlemen. When we talk about operationalizing emergency care at scale, the African Emergency Federation for Emergency Medicine, under the umbrella of the International Federation for Emergency Medicine, looks at the quality of the training that is provided by accrediting the organizations that provide this training across the African continent. But we do not only just provide the accreditation, we also provide technical support and direct support with our member societies at a regional, national, and subnational level to be able to ensure that this training happens at the remotest and in all across the African continent. When we look at the map that you can see on the left side of the screen, you can see the transformation of how many blues come up as we go through the years, through 2022, 2025, and currently we're at almost 13,000 providers for basic emergency care course, with close to 500 of them being facilitators, meaning that they can teach basic emergency care course, but 420 of them being master trainers. Not only can they teach, but they can also teach others to teach this, allowing us to scale quite quickly. We're also very proud to say that over 50% of all these numbers are nurses. When we look at the direct impact, we've seen all the numbers that have been mentioned, the reductions in Liberia, the reductions in Zambia, and a lot of other places. But what we don't see is what it means to teach a multidisciplinary group about emergency care. It gives you a structured ecosystem, people able to speak to each other in a common language that can save lives at the most critical need. The providers are not just trained, but they also gain significant confidence in the skill that they might have built throughout their professional training to be able to act as a team. And the most important part is that lives are saved through this. But to add to the numbers and to answer that question, that's basic emergency care at scale, reduce preventable deaths. We have seen this, and we have seen that about 50% reduction in mortality when simple tools are used, coordinated with support from ministries of health, national societies, to be able to promote this. We can see a significant reduction in deaths. We can extrapolate this to say that there is a reduction of deaths of one facility, one patient's reduction per week per facility. And if we scale this to the program that is coming, look at 1,000 facilities, we're looking at a reduction of 1,000 deaths reduction per week across the African continent. And we believe this is really significant, and we look for the support of everyone here to make this possible. Thank you very much.
Behind every number, there are lives. That is quite exciting to hear that number in 1 week. We can do this. It's always so thrilling to welcome the generations of leaders that will secure surely that this is an effort that continues throughout the years. I'm happy to welcome Anna Liakopoulou. She's a 6-year medical student from Greece who currently serves as a liaison officer for the medical sciences and research issues of IFMSA. Anna,
Thank you so
welcome.
much. Good evening, everyone. I'm Anna, and I speak on behalf of the International Federation of Medical Students Associations. And as someone that is soon going to be part of the health workforce, I wanted to share my own reflections about this discussion. And the reality currently is that in many medical schools, emergency, critical, and operative care are either scattered across different classes and disciplines without any connection between them, or they're barely or not taught at all. So a lot of students who are in their final years or immediately after the graduations are the ones that are treating the patients, actually the first clinician the patients meet when they go to the hospital or the primary care facility, sometimes in a rural district and sometimes in an emergency department. So they're stepping into acute care without actually having practiced it before. And students may know in theory, we might have heard about how to intubate or how to place a chest drain, but most of the time it's just theoretical knowledge. And even the ABC approach is a lot of the times not even mentioned within the curricula. So students rarely see these acute care settings. And the biggest issue, I think, we rarely see doctors practicing in teams. We don't see these things come together as one. We don't see these things under pressure in a resource-limited setting. And we learned one thing in surgery, one thing in internal medicine, and even the guidelines change from one place to the other, and they get updated within the years, but our education remained the same. And this makes things even more complicated. And when we graduate, or like in our last years, we need to put things together in a time manner. We need to provide the best care possible for our patients, and we're not able to. And the ECO approach makes this powerful statement that emergency, critical, and operative care are not actually different things. They are one discipline. They are the one way that we need to respond to a patient that is in crisis. And this philosophy needs to reach the classroom because if it doesn't reach there, we will not be able to save our patients on time. But the good news is that we don't need to make something from scratch. The evidence is there, the frameworks are there, WHO tools already exist, and in some countries, medical students already took action and requested from their universities to implement ECO. So our task is, as you implement the WHA 76.2 resolution and scale the global strategy, and the upcoming action plan to make undergraduate medical education explicit. To train the doctors that can save patients, not only memorize information, and ECHO should be not a consideration, it should be the basis, not an annex of our education. And this is actually a cost-effective approach because we will be more prepared when we get out of the university, not try to unlearn these silos later on. We arrive in the health system more prepared to save lives. We are the future workforce, and if we come out of medical schools and have to integrate, we have already learned the integrated approach, we will be able to give maximum outcome to our patients. So the call is very simple, I think. The students are the people that you need to invest in. We are here now, and similar actions need to be taken for all health students because it's not only medical doctors that are coming in touch with patients. We need this education, so please train us well, and we promise that we will carry this strategy forward. Thank you.
Thank you so much, Dr. Anna. I say Dr. Anna because you're really basically already there. So those things that you don't see are the things that you can help us change. You will save a lot of lives, for sure. It is a pleasure to also welcome Dr. Mariam Jashi. Honorable Dr. Mariam Jashi is the Secretary General of the Medical Women's International Association and the CEO of the Global Sexist Alliance. Welcome.
Your Excellencies, Chair, thank you for this opportunity. And on behalf of the Medical Women's International Association, that is 106-year-old international organization fighting for the rights, well-being, and health care of women, girls, and female medical professionals. And on behalf of the Global Sepsis Alliance, also joined by Professor Niranjan Kisun, the president of the Alliance, it's my delight to share one of the most important updates and landmarking collaboration of the Global Sepsis Alliance, WHO, the World Health Organization, Society for Critical Care Medicine, through the support of the Lardell Foundation. And I definitely take this opportunity to extend special thanks to Mr. Tori Lardell and the Lardell Foundation. The rationale for this landmark initiative was, despite the fact that sepsis is responsible for 1 in 5 deaths, 20% of lives globally are lost to sepsis. And despite the fact that it endures not only human but immense healthcare and economic burden to the societies, even in the 2050 investment report on the Lancet Commission, sepsis was mentioned only twice. And I'm very grateful that on your slides, Professor, you depicted 11 million deaths of sepsis. Despite 2017 resolution in sepsis, most of the member states have not yet prioritized sepsis in their legislation, universal health coverage packages, or funding portfolios. There are no dedicated earmarked funding from international financial institutions, donor governments, or global public-private partnerships like Gavi, Global Fund, UNITAID, or others. We have very limited, non-comparable data, and especially blind spots of data in low and middle income countries where the burden of sepsis is especially high. Finally, we don't have a coordinated research and investment strategy. And to address those gaps, the Lardell Foundation supported the Global Sepsis Alliance, SCCM, and the World Health Organization to implement 3 interrelated flagship initiatives. Under the leadership of WHO, starting from next year, we will produce the first global report on health system response to sepsis. It will be under the framework of emergency critical and operative care, but we are already extremely grateful for the opportunity to integrate sepsis-related questions for quality of care. The second direction is that under the coordination of the Global Sepsis Alliance and in partnership with WHO and the Society of Critical Care Medicine, we have already started development of the first multi-year global sepsis research strategy that will cover the knowledge gaps and solution gaps, starting from new vaccines to diagnostics, therapeutics, or evidence in clinical care, quality assurance, or epidemiology and data. Finally, under the leadership of Society of Critical Care Medicine and in partnership with WHO and the Alliance, we will generate very important implementation science data. How relevant, applicable, and effective are existing tools for emergency care, including sepsis, across different health care sectors? And the slide summarizes the 5 expected outcomes, the global report and the dashboard on health system response to sepsis, the multi-year global sepsis research strategy, sepsis research toolkits to help low and middle income countries in ethical research development, as well as the evidence generations from implementation and patient and family stories. Thank you very much for your attention, and we look forward to putting sepsis on high political agenda where it deserves to be. Thank you.
Thank you so much, Honorable Dr. Mariam Jashi. I would like to welcome to the floor Dr. Carolina Hedlock-Lore, the President of the World Federation of Societies of Anesthesiologists. Dr. Carolina.
Thank you very much. Excellencies, directors, organizers, colleagues, ladies and gentlemen, thank you for the opportunity to share with you all today. Pain, trauma, obstetric emergencies, surgery, critical illness, all of these depend on one thing: having healthcare workers who are trained, confident, and supported. That is why training is central to the WHO Emergency Critical and Operative, or ECO strategy. And this is where the World Federation of Societies of Anesthesiologists SAFE program can contribute. SAFE stands for Safer Anesthesia from Education. It's a practical train-the-trainer model designed for limited resource settings. It has several modalities: SAFE obstetric, SAFE pediatric, SAFE cleft, SAFE online, SAFE OR. Over the years, it has expanded across multiple regions, with most courses now delivered by local faculty themselves. What makes this model work is actually very simple. First, local ownership. The goal is not to fly in experts for a few days and leave. The goal is to help countries build their own training capacity, their own teachers, their own leaders, their own system for continuous education. Second, collaboration. Acute care does not happen in silos. Patients move from the emergency department to the operating room, to recovery, to critical care, to wards. Training should reflect the reality. Doctors, nurses, anesthesia, surgeons, and emergency teams need to learn and work together. Third, practicality. Training must match the reality on the ground. So SAFE uses simulation and scenario-based learning adapted to available resources, local disease burden, and everyday clinical challenges. The focus is on solutions that are realistic and sustainable. And finally, training also helps retain the workforce. When healthcare workers feel supported, recognized, and able to grow professionally, they are more likely to stay engaged in their health system and communities. I also want to highlight that the WHO Basic Emergency Care, or BEC course, and the SAFE program of the WFSA are complementary. BEC strengthens early recognition and stabilization of critical ill patient at the first point of contact, while SAFE strengthens perioperative and anesthesia care. So together, they support the patient journey. This collaboration is already happening in Honduras, WFSA, ICRC, Honduran Anesthesiologist Society, and other partners are piloting a hybrid BEC model combining online learning with anesthesiologist members of the local society and 3-day in-person training and strong local leadership. Colleagues, scaling up acute care training is not only about courses. It is about building people, strengthening teams, and creating communities of practice and systems that last. If we want that ECO strategy to succeed, sustainable clinician-led training must remain at the center of the conversation. So I thank you very much for your attention.
Thank you so much, Dr. Carolina Heloglu, for your always informed and passionate insight. I would like to also welcome now Dr. Luc Laviolette, who is the Head Secretariat of the Global Financing Facility.
Great, thank you very much. Excellencies, Regional Director Janabi, colleagues, really a pleasure to be here. It's actually been quite a great experience to hear all the different experiences from around this table. I see lots of opportunities for collaboration. So thank you for this opportunity to share briefly the Global Financing Facility for Women, Children, and Adolescents, the GFF experience in facilitating the scale-up of the Safer Births Bundle of Care, the SBBC experience in Tanzania. It's been quite a special collaboration between the government of Tanzania, Haydom Hospital, Lardal, UNICEF, and the GFF. Let me start briefly by explaining what the GFF is, because I'm not sure. It will help to understand what the scaling process was. It's a country-led partnership that was established at the World Bank 10 years ago at the onset of the Sustainable Development Goals. It's a country-driven model from its inception. 36 countries are members of the partnership, including Rwanda and Ethiopia, who are here in the room, and some of the highest burden and most fragile countries in the world. Our mission is specifically to end preventable deaths of women, children, and adolescents, and we have a focus on financing for scale. So this is why this experience should hopefully be interesting. It's a catalytic model that uses grant funds that we receive from donors to leverage the much larger volumes of World Bank loans. And these, of course, build on investments of domestic resources in the health systems, but we also align external financing around these projects, these large loans, and the one country-driven plan that we've helped countries prioritize. We focus on enabling countries to achieve better health outcomes for women, children, and adolescents by strengthening their systems, including the human resources that we've been talking about today, and by applying a financing lens to keep an eye on sustainability. During the first 10 years of the GFF, the trust fund that we have has mobilized $2.5 billion of grant funding, and this has leveraged quite a large volume of World Bank funding, so $11 billion of World Bank resources that have been applied to health. And I'm very proud to say that this works. When we look at the results that these countries have been achieving, and I want to emphasize that these are country results, all 36 of the countries have reduced maternal and child mortality in the last 10 years. And this is against the backdrop of stagnation on these indicators, as we know. They've achieved higher rates of service coverage than their peers. So other countries that could be part of the partnership but are not yet there, as well as faster rates of reduction of both maternal and child mortality. And what's particularly interesting is that previous to 2015, these countries were actually negative outliers. So they've turned things around. So congratulations. From the start, the GFF has recognized that scaling of innovations will be critical to achieve the mission that we have of eliminating preventable deaths of women, children, and adolescents. And so that's why through a competitive process, we selected in December 2019, the SBBC model in Tanzania as a model that we felt held really high potential for impact and was ready for scale up. I should emphasize that this was one of 5 that were selected out of 320 proposals that we received and full independent panel to evaluate this. So what is SBBC? We heard a bit about the cost effectiveness, just to unpack a little bit. It's a evidence-based maternal and newborn health program designed to reduce deaths during childbirth, especially in low resource settings. So really designed for that. It combines 3 components, and because it's in low resource settings, it really brings it down to the basics. First, clinical tools, so fetal heart rate monitors, resuscitation equipment, pretty basic, but innovations on those tools. Simulation-based training, healthcare workers practice the emergency birth scenarios using mannequins and simulators. And the training, importantly, and this I think is actually one of the key elements of success, is that it's a low dose, low frequency approach. Short repeated practice sessions rather than the occasional longer, larger courses. And third, and really important, is continuous quality improvement. So the birth and training data that is generated through this program are used in real time to identify problems and improve care right away. So there's a really rapid feedback loop. And it emphasizing a supportive learning rather than a blame, type of culture in the setting. So yes, it is about innovative technology, but it's mainly about using data for very targeted, supportive, and repeated team-based training. I want to emphasize, though, that it's not a vertical program, but a scalable frontline health system strengthening intervention. We entered it, so how did we partner for scale up? So we entered into this trajectory of scale up when Lardal Haydam Hospital, the government of Tanzania, had already spent some 10 years or so, right, in developing and testing and implementing the innovation on a more limited scale. So that first, I would say, incubation period. What we did is we used the grant financing to de-risk the integration of this innovation, this bundle, this package, into a larger scale program. So initially the World Bank Finance Project, which is very large, and then now in the next phase, it's nationwide through the national budget. So it's a sort of a stepwise approach to integrating fully into a national budget. And we know that in many cases, it's, this sort of valley of death of innovations is where things get stalled. This was large scale, and the experience I'm talking about is 300,000 births. We included the funding and we funded an impact evaluation. We heard some mention of it. It was published in February 2025 in the New England Journal of Medicine. Some of the most remarkable results that I've seen in my career. So a 40% reduction in newborn deaths, 75% reduction in maternal deaths. And I'll remind you that this is at a scale of 300,000 births. No? It's not a small boutique pilot. It's caught the attention of other countries, not surprisingly, and more widely within the World Bank. And we're really thrilled that at least 10 countries in Africa have already expressed interest in scaling SBBC in the next few years. And we have a generous contribution from the Lardal Scale Up Fund as a seed fund to attract others to catalyze this type of scale up in at least 10 countries. So I hope that this experience will resonate in terms, I saw a lot of links with what I heard earlier today, and in terms of how it can be applied to effectively scale up ECO programs like basic emergency care and safe anesthesia training. Thank you very much for your attention.
Thank you so much for your intervention. It is quite exciting to hear about investments in countries, investments in people, leveraging resources for change. And we encourage so much more of that. Appreciate your partnership. We have reached the last part of this evening, and it's one we've been looking forward to. We're sitting here with leaders of systems, people who have committed their entire careers to helping others. And we are going to talk a little bit about maybe what's what is to happen in the next 12 to 24 months, which for bigger tasks seem like a short runway, but we have seen that there are actions that can be taken. Before I go into the questions that I have prepared for you, we had the privilege of reading some of your trajectory, Honorable Minister. I also would like to introduce Honorable Minister Dr. Sabin Nsanzimana, who is Rwanda's Minister of Health, a physician epidemiologist and former head of the Rwandan Biomedical Center and University Teaching Hospital of Butare. He holds a PhD in epidemiology, has led major research collaborations, authored over 230 publications, and is a fellow of the Royal College of Physicians of Edinburgh. If I might say so, a fantastic human being, as I've had the privilege of sharing some time with him. Also want to welcome our highly respected and appreciated Tuur Lertle. And Tuur Lertle is the co-founder and executive director of the Lertle Foundation, a leading advocate for global patient safety and life-saving innovation. And I also have been made aware that today we will have the joy of welcoming Dr. Esrom Daoni, who's the Deputy Secretary of the National Department of Health of Papua New Guinea. We are so thankful that you were able to also make time for us. So I'm going to jump into some of these questions because we're looking at what can we do, and Honorable Minister Dava, I would love to ask you, what would you believe that the strategy for, certainly Ethiopia has supported the movement of ECOCare and its integration for years now. So you represent that commitment. Would you please tell us why the global strategy for integrated emergency, critical, and operative care is important to your country?
Thank you very much. And so want to say thank you, plus also excuse for coming a bit late, but really happy that my ambassador has represented us well. And it was exciting to hear from medical students to implementers on the ground, political will and political leadership you have through the ministers in here, but also institutions, global financing institutions, and Lardale, Global Health. It's always a pleasure to be in a room where we have also all entities, WHO. We can never achieve what we have achieved in reduction of maternal mortality, child mortality, countries coming together, including, I want to extend my appreciation and saying thank you to the government of Norway to still extend, I believe, on the ECO resolution that we had back in 2023, when Ethiopia has co-sponsored on that resolution, to what we would achieve in the future when the global landscape is changing and when everyone is looking at what can we do better. So want to extend my appreciation to the room full of energy, the room full of compassion and enthusiasm on what we can do better. And that's why Ethiopia's view the emergency and critical care is beyond resolution. When Professor was earlier presenting on the data, I've seen more around 2020, and things have changed since COVID. And even for us in Ethiopia, we are starting to explore more ways of investment, both on academic side, training more residents, training more professionals, more nurses, more midwives. But the number are still lagging behind a global average and even regional average, what would be expected for a care we want to see in operationalizing the care at the ground. So we have increased the number of facilities now who are giving emergency obstetric care. I will give you some tangible numbers. We have increased more care closer to the community through our primary health care initiative. The primary health care base is now expanding. We are bringing more surgeons, more clinical trained professionals closer to a primary facility. We are making comprehensive primary health care and health centers. We have built now more than 400, but now already equipped more than 350 health centers with emergency surgery to be more available. And we have seen significant reduction in number of referrals, number of days that we would have averted if emergency was closer to the community. And it is not just about equipment and facility building, but you need to equip it. I was really happy to hear around innovations, but we need to also train with low dose, high frequency previously, now with low dose, low frequency. A lot of innovations that we have to be equipped, and we need to also mentor. And there are catchment-based mentorship, catchment-based mentorship programs that we have instituted since 2019. Then COVID came, and digitalization is becoming another tool that we have added, where professionals can support from a remote on emergency EOC cares. So for us, the ECO platform is where we can bring innovation into action and push countries, push government for more commitment. Now we have increased the number of NICU and the number of child critical care, intensive care units to more than 80. Additional 80 institutions have been, centers have been added in the child NICU, and we have added more than 189 adult ICUs. Because you need to equip, you need to train, you need to add more innovation, and also use mannequins, use the simulations that you have, because we can reach more. There is a lot to speak about ECO, the need to invest on emergency care, and the need to integrate obstetrics and anesthesia, but the limitations are a lot because we need to expand. We need to work not only at a regional, at a country level. We work with the WHA, other regional entities. We work sub-regionally. I and Minister Saban and the other ministers closely work now to look at our health workforce. We're training more. We also exchange our professionals because the region has to be more integrated than ever if we want to achieve the ECO vision we set back in WHA 76.2. So these are some of the reasons, but just to give you one number and close, we have reduced the number of maternal mortality. The numbers that are being echoed in here are true. I'm an OBGYN by training. I remember the number of days we have when women were coming late, like 10% antenatal care and 10% institutional delivery back when I was in training in medical school. But now more than 80% of women come early for early antenatal care, and we can prevent earlier. And now the number of days we have has reduced. If you compare 10 years back, where the data was more than 800 maternal days per 100,000 live births, the current Ethiopian Demographic Health Survey estimate shows that we have reduced to 141 per 100,000 live births. It is a combination of efforts and our shared commitment. So I want to say, thank you, and we need to keep on this momentum because the number has to be zero preventable maternal days, zero preventable child days, and zero preventable human days. Thank you.
Honorable Minister, I'm so thrilled with that spontaneous applause, because when we're asking you about why this matters to your country, you bring us immediately to lives, and you have acknowledged that it's important not to only exercise leadership at this level, where you have obviously done exactly that, but also to bring it to local, regional, and the national level. Thank you very much. I would like to ask a question of Honorable Minister Sansimana, and I have to admit that at some point I said, Honorable Minister, I'm thinking about asking you something like this, and he said, no, ask anything you want. I will do my best. So he always does. I want to ask you, Honorable Minister, what are the effective mechanisms for coordinated actions and sharing lessons learned across countries that you have exercised or would propose so that the good lessons are spread widely and quickly?
I think what I had to say, Minister Daba has already said it to that question, which to me speaks on how we need to work together and share lessons from south to south, north, north. So any place you can get something to apply to your context matters. But I want to start by appreciating this invitation, because I'm used to going to infectious disease discussions and public health, very general topics, but now speaking about emergency critical care, has taken me back into the epidemiology shift that we experienced recently. We're looking back into our country data. By 2015, that's the first time we started to see more people dying from non-communicable diseases and injuries than infectious diseases. That's a very recent shift that happened, which pushed us to change also the structure of our healthcare system entirely. The way we communicate to people, how we design systems, and even how we allocate funding and resources. So we sat down and said, what are the 5 things you're going to do moving forward in the next 5 years? Number 1 was workforce development, the people. There's no way you can develop a system or a country without people well-trained in different specialties. And we even gave it a name, we called it 4x4, quadrupling workforce. We gave it a 4 years time. That includes nurses, midwives, and specialists and subspecialists. We also said, how can we catch up with time quickly? And embracing technology, including artificial intelligence, was also ranked number 2 as a priority, and is somehow cross-cutting. Then we moved into primary healthcare strengthening, because that's where almost 90% of our population seeking care, primary healthcare, community health posts, health centers. And we also got into how do we reduce maternal and neonatal mortality, the highest level, preventable mortality Minister Daba was talking about. And number 5 happened to be emergency medical care, critical care. So initially, that emergency medical critical care hasn't been a priority among the top 5. This is the first time we saw it coming. Given what I said, non-communicable diseases, we're seeing people dying from something that could have been managed within the first 45 minutes, an hour, that between the time an event happens and the time a response also was initiated. So we started each as a reform, and we got so great partners. Some of them are here around the table. I want really to appreciate your support, because this reform was probably the most often in terms of supporting. But now you're seeing more support to emergency medical critical care, probably than other reforms moving forward. And I personally think this is, if I have to choose one, I'll probably be biased and support this, because I've seen personal and close people being saved in a minute, or just dying because something didn't happen quickly. So what are we doing to that? We started by training people who could be doing this work. And again, in addition to the 4x4 strategy I talked about, we didn't have specific trainings for basic emergency care, paramedics, in our structure. This is the first time we started to initiate these. Some of these programs in Rwanda Polytechnics, University of Rwanda, are actually being launched this year. We'll be launching the first cohort this year for long-term trainings, but as we run also short-term trainings. Second is the ambulance systems in the country. We used to have 2 separate systems. You have an emergency medical service system in Kigali. Then outside Rwanda, it's just a hospital running one ambulance on its own, like a usual logistic or support. So now we put this together. So the new structure, the new governance, and we are seeing already results, especially in Kigali. The response time reduced from 45 minutes to 15 minutes in ambulance, from the time you call the time it comes to you. For those who visited recently, we actually have now a specific lane for buses, ambulances, and emergency care only. If you drive in Kigali and you use that lane, you'll be in trouble. And the money you pay, will be coming into our community-based health insurance scheme, which is also somehow a good contribution. So to respond specifically to your question, I think this discussion here highlights something I like. From resolutions and commitments, how do we move quickly into action? As an emergency, as we discuss emergency, how do we go beyond just talking about something and do it? So we had great partners. We are moving step by step as we get things in place. And October this year, we are actually reforming everything in our emergency medical services, from structures, from governance, from teams, even the ambulance colors, everything is changing. So I hope to host you in Kigali as we embrace into this 2.0 chapter in emergency and critical care. And there's no way we can do it alone. That's why partnership matters. So I think we'll be learning from Ethiopia, from Norway, from Papua New Guinea, and everywhere else. There's something to share. We look forward to that. Thank you so much.
Thank you so much for those lessons, Honorable Minister. I would like to also now ask Dr. Esrom Daoni, maybe what are the biggest challenges you see to integrating care at the different levels of the health system? We have now heard good stories, we have heard some lessons, we've heard about partnerships. So the integration isn't always that easy. So what are some of those challenges that you see?
Yeah, thank you, Mr. Chair. Excellencies, delegates, ladies and gentlemen. The biggest challenge for Papua New Guinea is connecting different parts of the system in a country with difficult geography, remote communities, high transportation costs, and even access to well facilities. There is also an imbalance in funding and resource across tertiary care and primary care. If you go to Papua New Guinea, it's probably one of, or if not the most diverse country on earth. We have 1,000 tribes and over 800 different languages. We have mountains, very high mountains to coastal and swamps. So it's actually a very challenging country to deliver healthcare, let alone emergency care. Emergency, critical, and operative care depends on strong links between communities, health centers, ambulance services, district hospitals, provincial hospitals, and tertiary facilities. In PNG, Papua New Guinea for short, those links are not always consistent. Referral can be delayed by distance, weather, road conditions, communication gaps, and limited ambulance coverage. The second challenge, and I think it's a common occurring theme here, is workforce. We need more frontline health workers trained to recognize and manage acute illness and injury early, especially in rural and remote communities and settings. This is why basic emergency care has been so important for PNG, particularly as it includes all cadres of health workers. That includes doctors, nurses, health extension officers, and community health workers. The third challenge is infrastructure and equipment. Emergency departments, operating theaters, blood services, oxygen, emergency care capacity, and referral transport all need to be planned together and not separately. The first challenge, I believe, and this probably is the most important one, and we can't see trends and manage our health challenges without data. Without reliable data, it is difficult to measure outcomes, identify gaps, and target investment. PNG is addressing this through trials tools, critical care registry work, but it needs to be further strengthened. We have a national health plan that we are striving to achieve to address all these things. And hopefully in the next few years, we intend to see a lot of impacts and outcomes, and definitely we will be sharing this with the global community. Thank you for giving us an opportunity to share what we are doing in PNG. Thank you.
Thank you so much for your message. Listen from Papua New Guinea. I would like to also ask maybe one last question, if I may. I know it's been a long day for so many, but this is an important topic. I would welcome the thoughts of our dear Tour Lerdo. Why would you think that investing in emergency critical care is important, and operative care is important? In other words, what kind of health impact have you expected to see as you have committed to this integration?
Well, thank you, Excellencies, Chairman, delegates, and friends and members of the ACON network. 3 years ago, we were gathered for the not only the passing of the resolution of ECO, but also for the establishment of ACON. And ACON was formed to help strengthen acute care systems. Yesterday, some 100 people gathered with more on the net to look back on what has happened over these 3 years. And it's an amazing story that we heard examples of here tonight. It also telling that there are 800 people attending this meeting, so it obviously has caught a lot of attention and interest. There are many things that have happened, and a few of them, and what is, I think, a common denominator for the programs that have been commented on here, is that it's a matter of scaling what has been proven to work. It's a matter of leveraging lessons being learned as we go. And it's a matter of looking at the various categories of emergencies together and look at synergistic efforts. The best solutions are not agnostic. And there are in particular two, I think, things that come through in several of the programs that have been mentioned. It is a paradigm shift in education from being a high bolus initial thing, and then you go out in a very clinical, very busy clinical service, to a system that is competence rather than compliance-based, that is supporting the workforce by low-dose, high-frequency, team-based training, that is leveraging new opportunities for data-based quality improvement. We have new technology and more is coming in AI. So it's possible to have much better information on what is happening and to improve the system. So I think a lot has happened, and it's a matter of really scaling now what we know works. And that is where ACON, that is where WHO, that is where the World Bank have a tremendously important role to play, because it often takes 15, 20 years to go from an initial breakthrough in science or new technology to this is scaled massively. And private funding is not often available through that length of time. So it's important that organizations like WHO and ACON that are sitting very close to the ministries of health can find out the best solution, what works, because the only way to have sustainable solutions is to prove beyond doubt that this is the best cost-efficient solution for integrated services. So I think it's really rewarding to see what's happened over 3 years, and coming towards 2030, I think there is so much more that can happen and should happen. A good story will find funding, and ACON is becoming a growingly good story, and many more should help to fund that story. Thank you.
So well said, as always. We want good stories. We have good stories, but we want more good stories. I'm being told that we have reached the end of the session. There's so much more to say. But we have started the evening with human stories, with examples of commitment, with examples of leadership, the notion of the obvious, the different data that calls for improvement, interventions that are already making an impact, showing that we can have an immense impact indeed by scaling up. Some very, very tangible examples, promising new generations, global reports with more information ahead, lots of opportunities, and a real demonstration from leaders of health systems that today have accompanied us to share from their point of view and experience what they see is working and where they want to go. I know that this is a very formal forum at this amazing place, but I want to maybe break protocol a little bit and ask the audience to please raise their hands if within the obvious is that they want to change lives and save lives. So it does open an opportunity for all of us to leave here this evening by thinking, what action can we take to move us closer to scaling emergency, critical, and operative care and change lives, especially where it's needed the most? Survival, dignity, and equity. So I'm going to ask one more time. Why are we here? To change lives? Why are we here?
To change lives.
One more time. We can do better. Why are we here?
To change lives.
Let's go do it. Thank you for your time this evening.